Yeah, feel free to, if you have a question, you can put it in the chat or you can just start speaking. I'll try to stop for those. But just to introduce a little bit, there's a few ways that you find congenital heart defects. You'll find sometimes you'll see, you might just hear a murmur. Sometimes you'll find that the child is always getting fast breathing. They're always being treated for chest infection, no improvement, just the same kind of thing, round and round, all those things. That's when you can think, okay, this child has a bit of maybe a heart problem. And then obvious things like cyanosis, I'm going to show you some pictures of that. And these kind of things will make you think, oh, okay, there could be a heart issue here. Now, ideally, yes, you do need an echocardiogram. You can't diagnose a child of having a heart problem without an echocardiogram. That's a very straightforward intervention. Now, they are not easy to read. You know, I've been doing echocardiograms really just the last 3 years, and still I'm not a specialist in those. Often I'll miss things, or it's very hard to actually see exactly what you're looking at. So usually it's good to get the images, put them on your phone and try to send them, whether it's the radiology, RADAID, ELWA group or some other group, see what you can find. And there are things which will prolong a baby's life. So when to suspect heart disease, the key thing is if you're seeing the SpO2 is not improving despite oxygen or CPAP, that's what we call a red flag for heart problems. Normally, if you have a child and they just have pneumonia or bronchiolitis or some kind of something, you put them on oxygen and usually you will see some improvement. But if you don't see an improvement, that usually means there's either a very, very severe pneumonia or there's a heart problem. Then you have other things. You have loud murmur. You might hear a very loud murmur. It's cyanosis. We know what that is. It's the bluish discoloration. That's a big red flag for heart problems.
Hello?
Also, poor weight gain. So we used to call it failure to thrive. Now we call it faltering growth. And any child who is on the nutrition program, you really do need to listen to their heart, because sometimes you'll find there's a heart condition which is not diagnosed very easily. So you've got to put a stethoscope on their heart and see if there are any murmurs. We had quite a few children diagnosed in that way. They come on the nutrition program and you see that they're not improving. You put a stethoscope on and you realize, oh, there is a murmur here. And then, like I was saying, the recurrent chest infections. The other thing, if children are in heart failure, the same as when an adult is in heart failure, you'll find the SpO2 will start to drop very quickly if they're lying flat. So that's why we talk about nursing them at 45 degrees, because the SpO2 will just drop right down if they're lying flat. So I want us to think about, there's basically three places. Yeah, if you can just mute yourself a second there. There's basically three places where you're likely to hear murmur.
Dr. Maggie, can Mr. please mute his?
Yeah, sorry, I'm hearing some. Let me just see.
Okay.
I just need to get everyone to just sort of mute everybody very quick.
Yes, yes.
There we are. So I'm just muting everybody. If you have a question, what you can do is put in the chat or put your hand up and I'll unmute you and then we'll do the question. So I'm not ignoring you. I'm just putting everybody on the mute so we don't have any issue there. So really three areas where you can hear murmurs most likely. Firstly, you have what we call the lower left sternal edge. Now you'll also hear these murmurs by the apex. So that's right, sometimes all the way right into the mid-axillary line. And if you're hearing that, that's much more likely to be a VSD. You often have a very loud murmur. Then you also have the upper sternal edge, which is more likely to be either aortic or pulmonary stenosis. Now, that is more common in an adult, but it can happen in a child as well. And then you also have the base of the neck, and that would make you think more about something else with the aortic valve, or maybe something called a coarctation of the aorta, which we're going to talk on in a second. But those are your areas where you're most likely to hear murmurs. Now, to hear murmurs is not always easy. People always have debate and discussion. I can hear a murmur, I cannot hear a murmur, blah, blah, blah. So you need to have the child usually quite quiet if you can, and in quite a quiet room. So peds ward or under 5 clinic is not an ideal area to hear the murmur. So if the child is stable, if you want to really hear it, I would take them in a small room on the side and just listen to their heart. Very good. Then when you hear a murmur, you have to think, is there a problem? So I'm going to take the answers away. What would make you think that a murmur was a pathological murmur? So what would make you think the murmur was giving the child a hard time? I'm going to unmute people so you can answer. What are the signs of a pathological murmur? Have a guess. Okay. I'll go through some. Yeah, so signs of a pathological murmur, basically there's a list here, but I just want us to think about them, the more likely ones. So basically, if you have a very loud heart murmur, it's much more likely that it's going to be pathological. Similarly, if you find that the murmur is radiating to other places, or there are other symptoms or signs. So a child who has a faltering growth, they're malnourished, they are, less than -3, they're very tired, they're breathless, you're seeing finger clubbing, all of these things, they would make you think that the child actually had a pathological murmur. Similarly, some other red flags as well. So a murmur, which is what we call pansystolic. So rather than it just having like a small kind of whoosh boom, it's like whoosh, 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 whoosh. You just hear all the heart sounds have been removed, and all you're hearing is whoosh, whoosh. That would tell you that the child almost certainly has a pathological problem in their heart. Similarly, a diastolic murmur as well. So remember, you have systole when the heart is contracting, diastole when the heart's relaxing. So with the heart's relaxing, you get a diastolic murmur, which means that there's a problem with the flow when the heart is relaxed. That tells you that straight away you know that there is a problem there with the heart. Basically, any heart lesion is very simple. You can categorize it into 2 broad groups. And this is by far the easiest way to, if you're speaking with a cardiologist as a family doctor, this is the best way to start to approach it. So you can say, okay, this is a child here with a loud murmur, and there is finger clubbing, and the child is cyanotic. I'm concerned they have cyanotic heart disease. If you say it that way, you'll know that the cardiologist will say, okay, this person is thinking about some causes. So you have cyanotic and you have acyanotic. Very simple. Cyanotic, they have cyanosis. Acyanotic, they don't have cyanosis. It's very simple division there. Then you have the more common cyanotic lesion. So I'm mostly going to talk about tetralogy of Fallot. Has anyone seen a child with tetralogy of Fallot? Something you've seen? We've had a couple. We've had a few. Yeah, Dr. Kamala? No?
No, I haven't seen. I think I've seen a child with a large VSD, but not with tetralogy of Fallot.
Oh, okay. Okay.
Yeah.
Oh, that's fine. Yeah, I mean, they're slightly different things, but yeah. Excellent. Okay, so tetralogy of Fallot basically it's like, the reason we call it tetralogy is there's 4 things that are wrong in the heart. So firstly, you have a very large VSD. So VSD is a ventricular septal defect. So you have, it's very big space between the 2. Then you have what's called an overriding aorta, which means the aorta takes blood flow from both ventricles. Then you have right ventricular hypertrophy combined with right ventricular outflow obstruction. So basically all of this means that instead of the blood going out of the right ventricle and going into the lungs to get oxygen, it ends up going all the way around the heart again, because it goes through the large VSD and it goes into the aorta and it goes all the way around again. So that's why it's cyanosis, because that blood that's coming back from the veins, it's coming back, it's needing oxygen. So it's blue colored blood, heart squeezes, out it goes, and then it goes all the way around the body. And it's basically deoxygenated blood going all the way around again. So here's a little picture. You can see, I think I might have shown you this a couple of weeks ago. I wanted just to show you again. Normal heart, nice and good. And then you have a heart where there's tetralogy of fallow. And you can see there's basically too much going into the aorta. And you've got a sort of blockage there of the kind of right ventricle there. But you've also got a VSD. And what you can see is happening here, this is your left aorta, your left ventricle even here. This is meant to be the biggest chamber of the heart. What's happening is all the blood is basically coming into it again from the right ventricle. So it's being pushed out to one side, and you end up with blood going all the way back. So essentially you end up with remodeling. And so usually they're cyanotic, but not usually at birth. So it's usually later on in life. They get clubbing, but they get what we call paroxysmal hypercyanotic spells. Now, these are also known as drop attacks, and people think that they're seizures, but they're not actually convulsions. What's going on is basically when the child changes position, so they stand up or they suddenly roll over or something like that happens, and they suddenly get a fast heartbeat, they start breathing fast, and they get cyanosis. And that means that the child basically gets suddenly very white and floppy, and they may briefly lose consciousness. They have a syncopal symptom. Now, we had one child, very, very sad case. When I was there in November, one child who had tetralogy of fallow, and it was basically uncurable because it just got sicker and sicker, and we could never get them off oxygen ready for transfer anywhere. And they just went right down, and we even had to use CPAP and everything, but they had these drop attacks again and again. It was very, very hard to manage. So really important just to be aware of that. If someone tells you you're hearing a murmur and someone tells you the child is always falling down or falling off or something like that, then you can know straight away, this is probably tetralogy of fallow. And then you have what we call, I'll talk about another one next. I just want to talk about the treatment, which is usually surgery. Over 90% of them would need surgery, but you can do some things in country before they're transferred, which will really help. So one of those things obviously is oxygen, but be careful, because if a child has managed to compensate and they've got themselves to a place where they are able to tolerate sort of lower SpO2 and they're not in distress, say their SpO2 is like 79, but you see the child is happy and playing, you don't need to put them on oxygen, because these children are used to running at low SpO2. What you need to do is look at the signs of distress. So if you see a child who is breathing very fast, or they have like really bad indrawing or something, then you need to put them on oxygen then, but you don't always need to be using the SpO2. These drop attacks, generally beta blockers are very helpful. So propranolol, you can start those. If you have it, you can use phenylephrine, but not always needed. Generally, a beta blocker slows down the heart, and that means that you are able to reduce the drop attacks. Really, very, very helpful way of doing it. So that's good. This is a very bad condition. I won't talk about it very much, because most of these children, even in my country and even in the States, they will die because there is very, very hard to treat. So if you see a child with transposition of the great arteries, usually you'll be called to a newborn. The child will be cyanosed, and the reason they're cyanosed is because their heart looks like the picture on the right. What's going on here is very bad. You see the aorta and the pulmonary artery, they're transposed, they're swapped. So they're in the wrong places. So basically you've got blood flowing into the right ventricle, then it's going out and into the aorta, and it's just going round and round. So it's the same, you know, the blood is coming from the body, supposed to be reaching the lungs. It doesn't happen. It just instead goes straight to back into the body again. So that's not very good because there's no way to get oxygen there. Then you also have, on the other side, you have blood going from the lungs. And instead of the blood coming in from the lungs and going to the body through the aorta, it's just going back to the lungs again. So if a baby has this and they have no VSD or PDA, they will just die. They will only survive if they have a VSD, something in between the ventricles to allow the blood to flow between the two sides. So that's why it's pretty much unsurvivable. So just to be aware of, immediate surgery is the only treatment here. But just to be aware of that possibility. So then we have acyanotic lesions. You have, basically, these are much more common and they are much more easy to manage because some of them will get better by themselves, which is great. So before we talk about those, any questions in the chat about cyanotic heart lesions? There are two other cyanotic heart lesions, but they're very rare, so I didn't want to put them in just yet. I'm going to give you a minute just to type everything. Okay, we can come back to that later. So acyanotic lesions, you have basically ASD, so atrial septal defects, much more common. And a lot of these children, basically, you may not even know that they have this problem because all that's going on here is you basically have a hole in between the two atria. So you have your right and your left atrium, and then between the two. Then you have what's called a patent foramen ovale, basically a patent foramen ovale is a fairly mild form of the illness. The foramen ovale is something that's there in basically in utero, and it means that blood just continues to flow because it just doesn't close up when it's supposed to at birth. Now you have two things. You have with ASDs, there's two types. There's an ostium secundum. That's the most common, and it's a fairly mild problem. You don't have a huge amount of blood going between the atria in that situation. Then you have ostium primum, much more serious, and usually ostium primums, they can involve the ventricles and other parts of the heart as well. So just to show you this echocardiogram, can you see, I don't know if you can see where the problem is, but I'll just show you, this is quite a good one. This is a good picture because what you can see, the thick areas down here, if you can see where I'm putting my arrow, these areas here, this is the ventricle. Oh, it's gone. This is the ventricles. Then you have your two atria here, these large dark areas. So anything that's white is basically the muscle tissue of the heart. Anything that's black is fluid, so it's blood. And this is the problem here. This is a gap between the two atria. So you can see here left and right, and what's going on here is there's blood flow between the two. And that means that you're going to have some problems. Now, sometimes people may not even know they have this condition. Other times they may just find that when they're exercising, they're more breathless, or maybe they have sort of episodes where they feel very dizzy or their heart can beat very fast. So ASDs, they may come basically, like I said, shortness of breath on exertion. If it's very bad, you'll get signs of heart failure. Now, in a child, heart failure looks a little bit different to an adult. You have some things that are similar. You have the edema, you have the breathlessness when they're lying down, but usually the edema can be in the sacral area rather than necessarily in the feet. So it's good to just be aware when you're looking at a child for edema, think about different areas where you might see it. So I'm just unmuting everybody again in case anyone has any questions. But that is basically ASD very, very simply. So you may get sudden collapse. Usually that would be later in life. There are incidents people might know about football players who one day they're playing on the pitch, suddenly they fall down they have a sudden kind of cardiac event. Often that's due to an ASD, and that can be quite hard to treat. Now, long term, if it's not treated, you get something called Eisenmenger syndrome. Eisenmenger syndrome, it's not complicated, but it's easier to show you in a picture. So that's why I've got this little picture here. So basically what you can see happening here is what normally happens in an ASD, or this one's a VSD, but can happen in either, is you have blood flowing out of your left ventricle. So it's coming back from the lungs, and you can see because their left ventricle is much more powerful, is pushing blood into the right ventricle, so some of it's going to the pulmonary artery. So that's why at this point it's acyanotic, because there's no deoxygenated blood going around the body. Now, Eisenmenger syndrome, what happens is basically the pulmonary artery is not used to handling that kind of pressure, so it starts to become very narrow. And so as a result of that, blood starts going back the other way. So instead of going from the left into the right, you get what's called a right to left shunt. So you get blood flowing from the right ventricle into the left ventricle and up through the aorta. And that is when you get cyanosis. So just be aware that it's not always simple as cyanotic, acyanotic. Sometimes you'll have a heart lesion like a VSD or an ASD, and you will have basically cyanosis going on there. So just to be aware of that. Any question about Eisenmenger syndromes? I know it's a little different, not something we see very often. Okay, no, that's good. That makes sense. So VSD, this is probably the most or second most common cardiac defect. 0.25% of the population have this, and many don't even realize. And usually it's just worsening breathlessness, or they have recurrent chest infections. Now in a baby, what you'll find is that the baby, they're just not able to feed. They're not sucking very well, and their weight gain is just very poor. They don't put on any weight. So you'll find that they find themselves in the IPF or the OTP. They're just not doing very well. But be aware, VSD patients are at risk of endocarditis. So any child with a VSD and a fever, you need to admit that child, because you need to be thinking about possible endocarditis. Even if they have another source of infection, I would still admit them, because endocarditis, as we know, very dangerous. You need prolonged antibiotics. But the main thing you find, it's a loud pansystolic murmur, left lower sternal edge. That's the classic thing that you'll find in a VSD. And probably, I mean, I've seen, I don't know, maybe about, probably about maybe 20 to 25 children in the last 3 years with VSDs. Some of them we've been trying to follow up in under 5 clinics. Often they just don't return, but some of them you'll see them again a year later and it's got better. Sometimes you'll see them and it's no better, and it's just getting worse. There was a plan with Catholic Hospital. They were trying to fly them to Italy to have surgeries, because VSD patients actually have a very good prognosis if you can do the surgery. So it was a high, what we call a high impact intervention to try and get a lot of these children to Italy. So that's something that we just, if you see them, it's worth talking with the team at Catholic, and when I come in, we're going to try to look at setting up that link a bit better so that we can refer patients there much more easily. But just be aware, basically most patients do end up needing surgery if they have an ASD, but a VSD, it's about 50-50. Some of them will close by the age of 1 year. Be aware, if you're seeing signs of heart failure, that's a bad prognostic sign. That means that the child's you know, their outlook is not very good if they have signs of cardiac failure. So it's very, very important to just be observing for that. So if you have breathlessness, if you have, like, you know, you're hearing crackles at both bases, all these things, that's a poor prognostic sign. Good. Any questions on ASD or VSD? I know I'm going quite fast. Okay.
Yes.
Yes, Dr. Matthews.
Yes, Dr. Mikey. I would like to know if by age 1 year the defect does not close, what then could be done immediately? Is it that you go to surgery or what?
Yeah. So good question. If it's not closed by a year, yeah, then you need to go to surgery. Yeah, most of the time you would need to go to surgery. Sometimes they'll close a bit later, but most of the time needs to be surgery.
So my understanding is that these patients are going to be followed up in a chronic care clinic.
Absolutely, yeah. So even once they've had the surgery, they still need follow-up. So Ernest, for example, comes in and out every 2 months. Ernest will come to the ward and we just meet them. Yeah.
I may be jumping ahead of management, but why could be some medical management why they are coming in?
Very good.
You manage them as they come based on the symptoms they come with?
Wonderful. Yeah, so we're gonna talk on that towards the end of the talk. I'm going to give you some ideas of how to manage them medically as well, because there are things you can do. So very good question. So we're going to reach to that towards the end. But very, very good point. And that is what has really, as much as the surgery, that's what will save these little ones, because they need to be stable for travel. So very good point. Okay. So just to be aware of this condition, we call this a PDA, patent ductus arteriosus. This was the thing with Finley that we were a little bit worried about at one point, but he doesn't have it, thankfully. It's very common in preterm babies. Basically, what's going on here, PDA, I think I have, yeah, there's a picture. You can see the left pulmonary artery and the aorta, they're basically joined. And that's normal in a fetus. That's part of a normal fetal development. What's a problem is if it stays patent after birth. And basically you end up with essentially a couple of things. You end up with what we call a wide pulse pressure. Now, difficult to measure this sometimes. We're not always measuring blood pressures in children as much as we maybe should do. But you also get what we call a machinery murmur. So the murmur does not change at all. It's always there. It's not systolic or diastolic. It's always, you always hear that same murmur. We're going to talk on management a bit, but you can actually manage them really with diuretics, and sometimes they will just close themselves. So, you know, we think that when our baby was born at 29 weeks, we think he had one, but then by the time we checked him again at 32 weeks, it had gone. He didn't have it anymore. So a lot of them, even after birth, they will close by themselves. So a lot of it is just monitoring. And we're going to talk about treatment a little more in a second after the overview of things. But I just want to talk about another condition. We touched on this a little bit with, you know, in sort of fairly recently when I was talking about Turner syndrome. But just be aware, coarctation of the aorta. Well, let me take away the answer. What is it? What is coarctation of the aorta? Anyone tell me what it is? Okay, don't worry. So it's basically a narrowing. So essentially a sort of constriction of the aorta, and it can happen anywhere along the aorta. It can happen right at the aortic root as it comes out of the heart, or it can happen kind of further down, you know, kind of in the abdomen, or basically anywhere. And it's usually, though, it's usually distal to the left subclavian artery. So once that branch has gone off towards the arm there, it's usually distal to that. Things you may see, I mean, this is one of the things that I always, these heart conditions are always frustrating, because sometimes we'll have situations where a child will die in the hospital, and often we don't even know why. And sometimes I think it may be a heart condition that is just hard to diagnose. But what you will find is that femoral pulses are very weak or even absent. So you're palpating, that's why it is a good thing if you're doing a newborn check. And I want us, in the next few weeks when I come in, we're going to look at the whole thing of newborns and OB ward, and how do we start putting newborn checklists in. And one of the things has to be femoral pulses. This is really important, because if you check femoral pulses and they're either very weak or completely absent, then you need to immediately be suspecting coarctation of the aorta. Other things you'll see as well, you'll see edema in the feet, and you get a murmur kind of higher up. It's not the same as a VSD, it's higher up, the upper left sternal edge. And then they may just go in heart failure or have these sort of circulatory collapses where they just suddenly arrest, or they just suddenly, things fall apart, and they get very bradycardic. So really important to consider. I just wanted to give you like a little kind of overview picture thing. So just some pictures of like, some of these common things and what they actually look like. So coarctation of the aorta is in there, and you can see, it's hard when I'm not there to point at things, but you can see the aorta there. It's suddenly got very narrow, and it means there's no blood flow, or it's very limited blood flow going down. So you often find the arms will be okay, all these arteries going to the up into the neck and into the brain and the arms, all that is fine, but there's limited flow further down. That's a coarctation. Patent foramen ovale, that's basically similar to a kind of ASD thing there. It's just not really closed. And you can see that there. And that's a PDA. And there's a little tetralogy. So I wanted to talk to you a little bit about, well, what do we do? Basically, what do we do if we're encountering these patients? And there are things you can do acutely and chronically. And I want to talk about what to do in an emergency. So this is, you're in the ER, it's 3 o'clock in the morning, the PA is seeing a child, the child is very short of breath, the PA calls you and come, and you hear some murmur, and you think, this child, I think, has some kind of some kind of heart thing is going on. So first things to do, we all know this. If you see a child with heart failure or respiratory distress, they need oxygen. Be very, very careful with fluids. If you give fluids to a child with heart failure, it can get a lot worse. So be very, very, very careful. Was one thing to say. Now, this is where you have a difficult situation, because these children, if they're breathing fast, they're not feeding, so they can get dehydrated. Similarly, if they are in heart failure, they can be, too much hydration. So what I would do with most of these children, if they're well enough to tolerate it, I would consider a nasogastric feed. That's how I would do it. I would not be wanting to put lots and lots of IV fluids in there, just because it's too much. Other things as well, frusemide, very helpful. I would start with 1 milligram per kg of Lasix. Now you can titrate that up. You can go to 2. You can even go up to 4 milligrams per kg in a real emergency. But I would start with 1. The reason being, if you go too fast, too quick, the child can have basically circulatory collapse. Then if they're tachycardic, digoxin is a very, very good thing to use. Usually 5 micrograms per kg is perfectly fine. And that is something we do have. You just need to really be monitoring basically be monitoring how it's being administered, because the dosing can get very complicated. So I would actually sit next to the nurse and ask them to show you what they are doing. So that's your kind of acute thing. And, renal failure, I know, I'm very realistic. In ELWA, our creatinines are not too accurate. So I would not be panicking about a creatinine, but I would be more focusing on any sign of shock or any sign of dehydration, anything that might be changing with the frusemide. Got to be very, very focused on that. Now, long term, the best thing you can do, really, if you have a VSD or an ASD, the thing that will actually keep them going is to consider an ACE inhibitor. So lisinopril is quite helpful in this situation. That will give you usually some, that'll give you some sense of, can give you some improved prognosis if you're using that. Again, you've got to be careful. You don't want to be giving it too much, but you're perfectly fine to maybe use 1 to 2 milligrams per kg of that to start with. And remember, you're doing monitoring, so you're bringing them back maybe like every 1 or 2 weeks to see how things are going. And then also you're monitoring for signs of endocarditis. So really any child with a VSD and a fever, if you can't find another source for the fever, they have endocarditis until proven otherwise. So you got to admit them. You may be looking at doing an echocardiogram if that's possible. And I would put them on 3 antibiotics, usually ceftriaxone, Metro, and Gent, or Augmentin, Metro, and Gent. In an ideal world, you would do a blood culture. Now that's very hard to do and very hard to get accurately. So you can certainly try if you have time to run across to Jamali or somewhere with your blood culture. That's a very good thing to do. But be aware that's not actually very easy. Okay, so that's what you got to try and do. So just a few thoughts. Be aware in the whole picture. So just hearing a murmur here and there is not a concern. It's more looking at the whole child. You want to be assessing for cyanosis. That will tell you one way or the other. And whenever you're classifying a heart problem, if you know if it's cyanotic or acyanotic, that will really move you in the right direction. And remember, don't forget everything else. So, children with heart failure, children with VSDs, they still get malaria, they still get pneumonia, they still get other things. We had one child with a heart problem, came in, this is way back in 2019, and they had heart failure, and we treated that. And then it's like everyone just kind of forgot about the pneumonia. And the child got very sick because there was also pneumonia. So it's really important to treat the other conditions, as usually 2 or 3 things can be happening at the same time. And as we said, the follow-up. So if you think there's a VSD, an ACE inhibitor is a very good idea, and even sending them home with a diuretic. And if it's tetralogy of Fallot, I would use propranolol. And you need to really educate the mothers, because they need to know when to come, like when to seek help in the hospital. So if the child is, if the child suddenly starts to deteriorate and they're not improving, then you have a bit of a problem. So you need to really encourage them to know when to bring their sick child. So I think I'll stop there. We'll have a little bit of time for questions. Any questions?
Dr. Mikey, thank you for the lecture.
Yeah, thank you. Thank you for listening. I'm looking forward to.
I want to know about the lists.
Okay.
So 1 to 2 milligrams per kg. How frequent are we giving it per day?
Okay. Very good. Usually once daily.
Okay.
But in an emergency, what you can do is you can do like 1 milligram per kg and then reassess after maybe 1 hour. If you're not seeing improvements, you can do another 1 milligram per kg after 1 hour. But when they're stable, usually once daily. Okay. All right. Thanks very much. I'm going to make sure that the video and slides and everything are available. And we'll be seeing you in about 3 weeks. Thank you.
Thank you so much, Dr. Mikey.